Okay, so welcome everyone to the MUMIS Prevision lectures. So basically, we're going to have a look at what's happening in Sem 2, taking a look ahead at what's coming up. So today will be around 2 hours total, hopefully. We won't go over that. But why are we here? What are we going through? Well, today we're basically going to run through what's new in Semester 2, what it's going to look like for you guys. And also, Raman's going to take a look at what's coming ahead in upper limb anatomy. And that's going to be the main part of today. Okay, so what can we all expect in Semester 2? Well, for the year ones, we're going to see a step up in face-to-face activities. That means that all active sessions are going to be face-to-face. We're going to have face-to-face clinical skills and anatomy every second week, every second week. And there's also going to be some face-to-face practicals. And that's going to be a lot more face-to-face than what you guys had in Semester 1, which will be really great, hopefully after lockdown, to see you guys back on campus. In Semester 2 as well, you're going to see a lot of anatomy. That's going to mean you'll have your Zoom classes like PACA, tutorial, imaging and specimens. It's going to mean a lot of self-guided learning, whether that's outside of the lectures and outside of what's up on Moodle, or whether it's going through the online quizzes and online modules that you'll see pop up on Moodle as well. And there should be some exciting, fun anatomy stuff as well that you guys get to do. But wait, what do PACA, tutorial, imaging, and specimens actually mean? Well, let's take a look at your timetable quickly. If you look at your timetable, you'll notice that there's 2 different blocks for anatomy tutorials, one on Tuesday, one on Thursday, and they each go for 2 hours. Basically, in these 2 hours, you'll have 2 different classes on each day. That's imaging, specimens, PACA, and tutorial. And so, for example, you might have imaging and specimens on the Tuesday, and then on Thursday, you'll have the PACA and tutorial, which will each go for an hour. What is PACA? Well, PACA is essentially a guided Kahoot. You run through a bunch of questions, and they're all based on the learning objectives for anatomy, and the TAs will guide you through those answers as well. And they'll ask for your input as well, and they'll call on you to say answers, which can be really intimidating, but also a really great idea to get involved. What about the rest of them? Well, tutorials, you're presenting anatomy information that you research in groups to your peers that are based on the LOs. In imaging and specimens, you're basically running through anatomy imaging in small groups, and it's the same for specimens, but you're actually looking at specimens. So what do I mean by that? In imaging, we can see we have an X-ray of the shoulder, and then we have some questions with it. And they'll ask you more specific things as well, like the bones, the structures, stuff like that. That's basically what imaging is. And specimens, again, very similar, but with specimens. So we can see on our right some anatomy specimens. These are actually what's coming up this week for you guys, and that's all up. It's all linked up on your Moodle as well. Okay, I guess some recommendations. These are not just recommendations from me, but from some other people as well who wanted to suggest some advice for anatomy this year. Well, basically with anatomy, it's a really good idea to try and learn things at your own pace. There's a lot of things to go through, and so keep on cracking through it over time, and having your own pace is a really smart idea, and not feeling too rushed with what's going on. But that being said, it's a really good idea to have a look at the relevant lectures before your classes. When you jump into imaging and specimens and PACA, you jump straight into answering and presenting stuff. And so you might find it a bit difficult to go straight from you might find it a bit difficult just to jump straight into that class without having a look at the lectures. Some people also advise to look at imaging and specimens content before, and you'll find that you often won't get through everything in your Zoom tutorials. You'll have some questions left over in PACA, you'll have questions left over in imaging and specimens, and so try and get through those in your own time, whether that's looking ahead or whether that's doing it afterwards. Now, as I mentioned before, there's a gap between the lectures and the tutorials as well. That means that not all content is going to be inside the lectures. And it makes sense, right? The human body is pretty complex, it's pretty intricate, and so we can't expect a 1-hour lecture or a series of 1-hour lectures to cover everything that we need to know. And so that means that we will have to do some self-study on the side or looking at what's uploaded on Moodle. And so having a look ahead can make you feel a bit more comfortable, a bit more prepared, and allow you to engage with classes. So what are some resources that can help us to learn stuff outside of lectures? Some recommendations from my friends who really love anatomy. Teach Me Anatomy. It's like your basic anatomy Wikipedia. Keep in mind, it's not 100% of your content, but it's a really good source to have a look at to get a basic understanding of what's happening. Moore and Daly, I've heard, is an amazing anatomy Bible to go towards, and it's really sort of suited to what we study in Monash. And then for the Ankias, Dope Anatomy is a really good anatomy deck. It's actually a deck that I used, and I found it super helpful for upper limb as well, jumping straight into it. All right. Well, what's up with these face-to-face weeks for anatomy? a quick heads up that there could be some differences between what's happening this semester, and that with COVID and everything, of course, we're relying on those changes coming through. But basically, you're going to have both online asynchronous activities as well as face-to-face specimens in those weeks. And specimens is a really cool session. I won't spoil what happens, but the online asynchronous stuff is basically like quizzes and modules. But it's nice to have a little bit of a Zoom break, and it'll be nice for you guys to come in on campus as well. What else to expect in semester 2? Well, clinical skills is not just about histories anymore. You will be taking histories about your patients, but they'll be specific as well to like systems, and you'll learn how to examine patients. Your ICLs are also in smaller groups, and we know that you guys love your tutorial groups. So sorry if I having to like break them down and make them a little smaller, but faculty has really wanted to increase participation and engagement, and so based on some feedback, they've decided to go with these smaller groups. And also PSBs will really be your best friends this semester. For anatomy, for cracking through everything that you have to go through, they really are useful, and especially for getting an idea of what you need to know. So yeah, as you guys will know, PSBs are really amazing. Okay, while we're here as well, just some other fun stuff that's going to come up with the SEM. I'm sure you guys all saw the MedBall post. So look forward to that. It will be an amazing event. And of course, he's been organizing some amazing events. Shout out to him for his amazing work. If you need help this SEM, please reach out. It can feel like a bit of a step up, especially from semester 1, but you have a lot of support. Brittany's doing an amazing job as well with the academics and being your providing all that support, and as well the support services that Monash has and the faculty has, which you can find on Medal. All right, but that being said, let's jump into everything of note today. So I'll hand it over to Raman, who will start taking us through upper limb anatomy.
All right. Thank you. Okay. Cool.
Oh, sorry.
All right. Yeah,
sorry. I'll quickly share my screen again.
Yeah.
I'll send through the chat. Oh no, sorry, I misread. My bad. I'll send through the link as well to the slides. But I think Raman will also mention about the slides.
Oh yeah, right. Okay, so basically, well, the purpose of this presentation or this lecture is just to give you an overall view of everything that you'll cover, or most of the key stuff that you'll cover in upper limb. Can't remember if we've mentioned or not, but with anatomy, you'll be covering the upper limb, lower limb, thorax, and that's your chest, and then your back. All right. And so for the first half of SEM 2, I think it'll just be upper limb and lower limb. So those are the biggest. And so I thought, okay, well, given that you have to do a lot of pre-learning before you get into your lectures and your tutes and your practicals and whatnot, it'd be a good idea to just give you an overview so that you kind of know-ish what you're going into. I don't expect you to, after going through this presentation, remember all the muscles, all the bones, all the nerves and all that. In fact, I probably don't expect you to remember much of it. The purpose of this is that when you go into those tubes and into those lectures, into those, whatever you're going to do in uni, when you see, this particular nerve, you're like, oh yeah, actually, I remember that. It's familiar to me. Okay, rather than going, okay, what the hell is this? I've never even heard of it in my life. So that's why, I don't really, you don't need to take notes or anything. Because basically all this stuff, and that, again, you don't really need the slides either, because a lot of this stuff I've just taken from my notes. So if you want a summary, you can go there. But again, I wouldn't stress about taking notes or sort of memorizing anything that I'm going to say here. Just sit there and just absorb it so that when you get into your tutes and your lectures, it's like you have a base to go off. So kind of doing the pre-learning for you a little bit here. All right. So without further ado, we'll get cracking. So first up, I should just give you a brief overview of what we'll cover. First off, we'll go through some key terminology that'll cover you for all your anatomy, basically for your imaging and stuff like that, because there's some new terms that you should be familiar with, which they don't actually tell you. So it will be good to just sort of go through all of that so you actually know what you're talking about or what they're talking about. Then we'll go through the upper limb itself. So we'll talk about the bones, then the muscles. Then we've got nerves and vasculature and some important spaces that we'll know. There's only a couple of them, but we'll go through them anyway. All right, but we'll start off with some terminology on describing things in general. I couldn't come up with a better term for it, but basically, okay, this is just the terminology you'll use for describing the positioning of things. Okay, so you'll see these in the imaging, okay, in specimens. All right, so it's good to get your head around them. And, you know, it'll take maybe, you know, a week or two, but, you know, I wouldn't bother too much. It'll eventually come into your system. So when we're talking about front and back, we're going to be talking about them in terms of anterior and posterior. Okay, so you might have heard of ventral and dorsal from your SEM1 stuff. Okay, that's the same thing. Anterior, posterior, ventral, dorsal, but on your imaging, your x-rays and stuff, that'll be classified in, as you know, anterior and posterior. Next up, we've got superior and inferior. Those are pretty straightforward. So if you're superior, you'll be up near the top of the head, inferior will be down towards the bottom. Okay, but obviously all of these are also relative terms. So for example, the nose is anterior to the spine, and your knee is inferior to your hip. Okay, so you'll be seeing that kind of stuff that you mentioned. In terms of, I guess, left and right, it's a little less simple as left and right, but basically you've got your midline, which runs through the center of your body. Okay, and medial just refers to things closer to the midline, and lateral refers to things further out. So if you think about it, this might be a little bit better. So it's not necessarily left or right, it's more so just in relation to the midline. Okay, so for example, your belly button is medial to your hip, I guess, or your arm. And your thumb would be more lateral in this image to your pinky, for example. Proximal and distal refer to the distance of something from, I guess the sort of the center of your body. It's a little bit harder to describe, but basically for the upper limb purposes anyway, your fingers will be more distal than your shoulder, for example. It's again, a little less straightforward because it's not exactly like the center of your body, so to speak, but if you can kind of imagine someone with their arms out and their legs out, you can sort of see how something might be more distal and more proximal. And then your feet are basically dorsal, and this is kind of where it's a bit odd because remember we said dorsal and ventral was for anterior, posterior, front and back, but for your foot, the top surface is dorsal and the bottom surface is plantar. So like you're planting your foot, there might be a way to remember that it's the bottom. And I guess the dorsal fin on a fish is at the top, if I remember correctly. So maybe that might help you remember. Again, like this, once you just keep talking about it, eventually you'll just get into your system. And for your hand, similar kind of thing. So dorsal will be the sort of back of your hand, and palmar will be the palm of your hand, the palmar surface. All right, okay. Now on to attachment. So this is not as important, but I thought I'd just mention it because sometimes these words can be a little bit odd if you haven't seen it before. All right, so origin is where, because you can see the diagram, a muscle has two attachments. All right, it's got to attach on your bone somewhere. All right, and so the attachment at the top where it sort of comes off the bone in a sense is what we call an origin, and where inserts comes back to the bone is what we call an insertion. Okay. Yeah, I don't say anything else about that. Tendons are these white things here. Your muscles, obviously, the red stuff. Ligaments are going to be these connective tissue around joints and things, which you might have touched on last semester as well. And bursa, I'll get rid of this. Yeah, bursa, I don't know if you can see, but that'll be this little circular sac thing on the elbow. So this is in the elbow. I think there'll be one on the shoulder as well. So often around the joints, you get this like fluid-filled sacs, okay, called bursa. And I won't go into too much detail about them, but they exist, and we'll probably be talking about them later on. But that's what they are. Okay. All right. Just some quick terminology with bones. These ones aren't as prominent, so I won't talk about all of them, okay? But the main ones are tubercle and a tuberosity. So there'll be like sort of bumps and humps. Again, it's probably the worst way to describe it. But once you start labeling the bones in your tubes and stuff, you'll start to see, the different tubercles, the greater tubercle, the lesser tuberosity, all that stuff. But they're kind of just like projections in a sense. Fossa, you'll see the word fossa pop up. That's basically just a cavity or a depression. All right, this is a terrible drawing, but that might be a fossa. So for example, if you imagine this is your shoulder joint, this is that's this bone here. This is I guess, the shoulder joint part. The fossa will just be the little cavity that kind of holds the ball. facets, I won't know too much about those processes. Again, you'll see these again, so I won't go through them too much. I guess the only other one that you'll see coming up a lot is foramen, which is, again, just like an opening. So you'll see some of these words cropping up again and again, especially fossa and foramen. The other ones, I guess, you just kind of memorize. Not too important at this stage. All right, so hopefully that made a little bit of sense. Again, first of all, these will be in my notes. You'll see some of the diagrams are quite similar, and there are very neat summaries. I'm sure the PSPs will be putting out some summaries as well. All right, so now with the upper limb and lower limb, I guess actually all the musculoskeletal system, there are different movements you can make, obviously, because your whole musculoskeletal system is composed of muscles. All right, so each of them come with different terms. Again, things you're just going to have to know. All right, so here is a list of the relevant movements for the upper limb. Okay, they're mostly similar for the lower limb, which is with some exceptions. Okay, so we'll go through them a little bit in a little more detail in a second. All right, but these are just some ways that I personally kind of use to remember. Obviously, you can come up with your own ones, and forgive me if they're a little bit cringe. But for example, flexion, I imagine flexion as bringing body parts closer to you. Okay, so if you think about flexing your biceps, you're bringing your arm closer to your body. Whereas if you extend your arm, you're taking it away. All right, abduction. Basically, if you're abducting your arm, you're lifting it up. Or so I guess your shoulder, you're lifting it up. You're taking it away from your body, like kidnapping, I guess. Adduction, I couldn't think of anything, so I just thought of it as the opposite of abduction. So flexion and extension are opposites. Abduction, adduction are opposites. Supination, pronation are opposites. External and internal rotation are opposites. So for supination, it's kind of rotating your hand. Again, we'll go through these in more detail. These are just ways you can remember it, though. So I like to think of supination as, if your Superman goes like this, all right, let's just be the opposite of that. So you're rotating your wrist out. Pronation will be rotating it inwards. External, internal rotation should be fairly self-explanatory. And opposition is basically where you, like, basically touching like your fingers like this. But yeah, all right. But I can appreciate that this might not make too much sense at the stage. So let's have a look at some diagrams, courtesy of PS Papa from our year. They made some very nice drawings. So basically, with your shoulder, so basically I've categorized the movements moving around the joint, because that's where you move, right? Your shoulder joint, your elbow joint, your wrist joints, your finger joints. Okay. So for the shoulder joint, your flexion will look like this. Okay. Moving away from your body, I guess you can, or not sort of, I guess if you continue the arc, it'll come right back to your face. So I guess in a sense that kind of fits with the like, I guess my technique for memorizing what flexion is. Extension, again, opposite, moving backwards. Clear that. With your internal and external rotation, if you look at the diagrams, internal, you're moving the shoulder joint inwards. So if you kind of move your arm inwards, a little bit hard to demonstrate on Zoom, which is pretty, it wasn't live, but anyway, we'll make do. You're kind of moving the arm inwards. So you think about the joint, because again, this is all in relation to like the arm and the joint. You're moving it inwards, external, you're rotating the shoulder outwards. Adduction, I guess you're moving the shoulder away from your body. I think that should be opposite. Just keep it over there. Yeah, I might have marked up the definitions for the previous one, but yeah, adduction, abduction, okay. Flexion, extension, same thing, but with your elbow joint now, right? You're moving your arm close to your face. Extension, you're moving it away. With your wrist joints, now I've got extension and flexion, same thing pretty much, just kind of slightly different location. Supination, pronation is what I was talking about earlier. Supination, I guess, kind of the opposite of what Superman pose would be. Pronation is the Superman pose, so the opposite of supination. Your wrist, adduction, abduction, basically moving it left or right. And that's why, if you noticed on that first slide, I also called abduction and adduction as radial and ulnar deviation, because as we go through with the bones, your ulnar bone is here and your radial bone is here. So if you abduct your wrist, you're moving it towards the radial side. If you adduct your wrist, you're moving it towards the ulnar side. So you might see ulnar and radial deviation as sort of synonyms for abduction and adduction of the hand. Flexion and extension of the fingers now again. So we're going through each joint, as you'll see. So there'll be different, and with the leg as well, it gets a little bit more complicated, but essentially I just try to remember it as flexion is moving it closer to you, extension moving it further away, but you can come up with your own ways of remembering it. Abduction and adduction. So abduction is moving fingers away from the center, adduction moving it towards. Again, now you've got the thumb. The thumb can be a little bit complicated because it's in a weird position. So this might take some getting used to. I won't spend too much time on it now because I doubt anyone's going to remember it. But I just recommend you pay a little bit more attention when it comes to understanding these. So you'll have to spend a bit of time on your own just kind of understanding it because they won't teach you this. But it's just good to have, be on top of all these terms so that you're not struggling to balance too many things when they're just discussing it in class. Flexion, extension, yes, I won't go through those. Opposition is the only one that's unique. And that's basically where your thumb goes and sort of connects with all the other fingers. Okay, all right, so now we get onto the actual content, I mean, not the actual content, but the actual system. All right, so we'll start off with the bones of the upper limb. All right, so on the diagram on the right, all the stuff that is, I guess, it's a bit hard to see, but the stuff that's not faded is going to be a part of the upper limb. All right, so the list of bones that you should know are on the left side here. So which is which? Kindly demonstrated that for you. So you got your clavicle or your collarbone, your scapula or your shoulder blade, your humerus, your radius and your ulnar, which we touched on previously, and then your hand bones, so your carpal bones or your wrist bones, your metacarpals and your phalanges, which is like your fingers, basically. Oh, well, actually, metacarpals and phalanges are both part of your fingers, technically. But anyway, we'll cover those in a little bit more detail in a second. So I've also broken up, and I'm not sure, can't remember actually if they do this as well, but they will focus on the joints as well, because obviously there are specific things that you need to talk about in terms of ligaments in regards to the joints that we won't talk about. But that's how I've kind of broken up these bones are into the different joints. So we've got the shoulder joint, which is the otherwise known as the pectoral girdle or the shoulder girdle. So if you hear that, you should be thinking about this particular joint. And the bones that make up this joint are the clavicle, the humerus, and the scapula. Okay, so that, just for a little bit of reference, that's your joint basically there. All right, and so if you look, it's a bit hard to see, but you can see this little depression there where the humerus sits, that'll be your glenoid fossa. It's fossa because it's like a little crater for the humerus to sit in the ball and socket joint. So yeah. Now, I won't go through this for each bone because again, there'll be zero chance that anyone remembers any of this, but this is what you'll need to understand for each bone, is the different bony landmarks for each bone. So for example, we'll just go through for the humerus, but remember we talked about the tuberosities. Okay, that's evident on these bones here. You've got, I think at the bottom as well, you've got the medial and lateral epicondyles, all these different things that you'll have to familiarize yourself with because they'll be important in imaging. Okay, and specimens when they're asking you to describe certain things. The shaft, when you have a humeral shaft fracture, you know what you're talking about. Fracture of the medial epicondyle, what are they talking about there? Okay, so that's why it's good to be familiar with the different landmarks of the bone because, clinically, obviously, when they have fractures and things, you have to be able to identify where the fracture is. So we won't go through these, but again, all in my notes, and I'm sure online as well, Teach Me Anatomy will have most of this stuff as well. Just a side note as well, you might notice, especially with the muscles, that I've put these little Latin to English interpretations next to the name. That personally, I just found that particularly helpful just to remember what the muscle was. You might find that particularly helpful or not, but there are a lot of different muscles, because you're thinking about all the muscles in the legs and the arms and the back and the chest. There's a lot to remember. Okay, so if you can come up with some sort of way to help you remember, I'd really recommend that. And so, I'll give you a few tips, but obviously, I think personalizing it is going to be much better. Okay, all right. On to the next joint, which is the elbow joint. Okay, that involves the humerus, the radius, and the ulnar bone. Okay, nothing much more to say there. I suppose, again, there's a lot more detail to go into on the joint itself, but we won't do that now because there's different ligaments and things. And for the wrist joint, we've got the carpal bone. So that's the wrist, your metacarpals, which form your palm, and then your phalanges, which are numbered. So all the metacarpals and the phalanges are numbered, from your thumb being 1. So if you say like the 5th phalange or phalange 5, you're talking about your pinky finger, basically. And again, a little bit detailed, but I don't expect you guys to remember this now. But each of the carpal bones have a name, okay, which might be a lot to remember again, but there are different mnemonics that you can use. And yes, I realized that this is not how you spell mnemonic. I was under the impression that this was the entire year until later I realized, so just forgive me for that. But, you know, for example, in mnemonics like this, you know, straight line to pinky, here comes a thumb, can be useful to remember bones like this. Like, for example, in the feet as well, you have another set of 8 odd bones that can be hard to remember. So it's good to come up with your own sort of mnemonics to help. Otherwise, it might get a bit tough. But okay. Yeah. All right. So those are your bones. Okay. Now for your muscles. Now there are a lot of muscles. Again, I don't expect you to remember. I'm just going to try and show you how I personally would go about trying to remember these. So again, I've broken up the muscles into several categories. So you've got your shoulder muscles operating, because again, the body only moves around the joints. So the way that I categorized my learning was around joints. I'm not saying you have to, but that's just what I found the easiest. Okay, so got your shoulder muscles operating the joints. You've got your upper arm muscles operating actually both the elbow and a little bit of the so mostly the elbow. Forearm muscles operating, I guess, the wrist, and the hand, and your hand and wrist muscles obviously operating the joints in your hand. Okay, so again, a lot of muscles to remember. We won't go through all of them. Either we will go through all of them, but we won't, you know, don't have to memorize them all. But yeah, this is going to be a bit of a challenge. Probably the biggest challenge, I reckon, is just remembering all the muscles and the innervation and the blood supply and all that stuff. But all right, we'll give you a quick introduction now. All right, so the shoulder muscles. These are all the shoulder muscles that you need to know. Okay, looks like there's only 4 there, but there's a lot on the inside. So you've got 3 different subcategories of shoulder muscles. So you've got the extrinsic shoulder muscles, which are then subdivided into superficial and deep muscles. Okay, so your trapezius, latissimus dorsi. Again, I won't go through all of them right now, but these are just ways that they are categorized. Some of you might have heard of the rotator cuff, like rotator cuff injuries. All right, so these are going to be particularly clinically important because, you know, rotator cuff injuries are quite common. But yeah, side note, and your pectoral muscles as well. So all of these make up the shoulder, all right, because they all are involved in the movement of the shoulder. And basically the number one way that I try and remember what the function and the innervation and the blood supply, etc., of these muscles are is through just, for me personally, acting it out. Okay, what is the function of the muscle? Where is it located? How are they related? And I'll show you what I mean in a second. Let's have a look at the extrinsic shoulder muscles. So for example, the trapezius. Again, I've put these little ways you can remember it. So paired muscle forms a trapezium. No, not that it's going to be too hard to remember that. Latissimus dorsi, latissimus in Latin means broadest, dorsum means back, so the broadest back. But anyway, that may or may not be very helpful. Okay, but basically, if we have a look at the insertions and attach like the origin of the trapezius, for me personally, that can help decide sort of what the function is. Because I'll be honest, I haven't memorized all the functions. You know, I haven't touched this entire system since last year. Till I made this. And so I'll be honest, as I go through the function, I don't actually remember the functions that I've blacked out here. Okay, but I might not be entirely correct, but we'll see if I can guess it based on the attachments and the origin. So for the trapezius, it's attached onto, I think, either the clavicle or a scapula. I think it's a scapula there. There would be a scapula. Okay, so let's think, if the muscle contracts, it's going to pull, right? It's going to get closer together. So if the muscle pulls, it's going to pull on your scapula, and it's also attached here. It's going to pull in a couple of different directions. So if I had to guess what the function of the trapezius would be, it would be external rotation. So if you think about it, if you're contracting the scapula backwards, you're externally rotating your arm. So I would say external rotation. would be one of the functions of the trapezius. And the other attachment, if you contract it, moves up. So that would be, I think, abduction or adduction, one of the two. See, I'm already forgetting. But one of those two. So let's have a quick look. Elevate, okay, so it didn't say, but elevating and rotating the scapula. Okay, all right. So there, correct, based off just by looking at what the sort of the attachments are and logically what would occur. Right, and for each of these muscles, I've included innervation. Don't worry too much about that now, but you will have to remember those things later on. And there are different ways you can remember it, for example. Well, I'll go through them later on, but for the latissimus dorsi, okay, again, looking at where it attaches onto the humerus. If it contracts, where is the humerus going to go? Right, it's going to go, well, a couple of different ways, actually. One could be external rotation, because you're pulling it backwards. Okay, another one could be, I guess, extension. If you're pulling the humerus backwards this way, that's extension of the shoulder. Right. Potentially also a bit of, I think this is adduction from memory. Again, I always get those two confused. But something either adduction, abduction, you've got external rotation and extension. Might be at least one of those three. Let's have a look. Yep, adduction. Okay, yes, adduction is bringing it down. Adduction, extension, and medial rotation. So medial rotation is going to be the same as internal rotation, okay, because you're rotating internally. So I said external rotation, but it's actually going to be internal. I think because if you look closer at the attachment, I think it's on the inside of the humerus, or can't quite see it on this image, but I'm sure if you look a bit closer on another image, you'll see where it's attached particularly, and that might tell you, okay, it's actually going to be a bit of internal rotation. I think I thought it was attached on the outside, but I think it might be attached on the inside of the humerus there. So as you can see, that kind of logical process of deduction is what I personally used to try and remember the functions and basically a lot of the stuff in MSK. And actually for a lot of those systems anyway, I like to take a bit more of a logical approach, which requires less memorization. Not saying that's the best approach, not saying it's the approach that'll work for you. But that's one thing that you can consider using, especially since there's just so much content. If you're somebody who doesn't like memorizing or just finds it very difficult, this might be another approach that you can use. It might take a little bit longer, but for me personally, it helps understand. So I won't do that for every single muscle, to spare you the pain of watching that. But again, all right, so different muscles have different functions. I won't go through all of them, okay, because you can look through this at your own time. You don't need me to read it out to you. Okay, so yeah, again, having a look at it, we'll touch on this one. So deltoid muscles, I'm sure that you who go to the gym will have heard about your deltoids, okay. Again, thinking about what it does, it's attached here. When it contracts, it's going to be pulling upwards. So it's probably going to be involved in, I think, abduction of the shoulder. All right, and the teres major, look at where it's attached. If it contracts, I think it's going to be medial rotation. All right, so I'm just imagining this, like in real life, like if my teres major was to contract, where would it go? So yes. Okay, now the deltoid arm is, okay, again, this is clinically relevant, particularly is the degree of which it can abduct, because as we'll talk about with the rotator cuff muscles, they also do abduction of the arm. Okay, so if something is damaged, you might have limited abduction, but we won't go into that now because it's a bit extra. Okay, yeah, so this is the rotator cuff muscles. So if you had a rotator cuff injury, this is what you're going to be dealing with. Again, logically, looking at where they attach, what do you think the function of the rotator cuff is going to be? I mean, the name kind of gives a little bit away, but for example, if you look at the supraspinatus, which means above spine, supraspine, and if you learn the bony landmarks of the scapula, this is the spine of the scapula. Okay, so supraspinatus is above the spine of the scapula. Okay, so I know where it's going to be approximately. So if you're looking at a specimen and someone says, okay, where's the supraspinatus? You can say, okay, well, where's the spine of the scapula? What muscle is above it? Okay, that must be the supraspinatus. Okay, infraspinatus, what's below this? Below the spine. Often you'll see muscles being major, minor, like teres minor, pectoralis minor, that kind of stuff, major, minor. I don't know if there's any reason to remember that, but yeah, just something to mention. But yeah, again, if the supraspinatus contracts, all right, what's going to happen? Your humerus is going to be abducted. So again, if you have damage to your supraspinatus, what's going to happen? You're not going to be able to abduct as well. Given that the deltoid also does shoulder abduction, you might still have limited, because I think, yeah, the supraspinatus abducts your arm to about 15 degrees, then the deltoid does the rest. So if your deltoid isn't working, or you've got some damage or tear in your deltoid or something, you'll only be able to abduct your arm to 15 degrees. So if a patient comes in and they can only abduct their arm to 15 degrees, you can start thinking, okay, there must be some issue either with the deltoid muscle or the innervation of the deltoid muscle. And this is where, towards the end of all your learning, you'll start to piece together the clinical implications of all the nerves and stuff. So all this stuff has importance, because if we go back to the previous one, so we know that the axillary nerve innervates the deltoid muscle. So if somebody can only abduct their arm to 15 degrees, you'd be thinking, okay, maybe there's some damage to the axillary nerve because he can't move the deltoid. Whereas all of these, except for the teres minor, are going to be innervated by the suprascapular nerve. So they're not going to be affected if the axillary nerve is dead for whatever reason. But maybe whatever function the teres minor have, if you know the external rotation of the arm is less, it's not going to be gone because the infraspinatus also does external rotation. But if it's a little bit less, you can sort of piece those puzzle pieces together and say, okay, well, you know, there's a good chance that the axillary nerve is damaged, and you can do some other tests, blah blah blah. And we'll talk about the nerves a bit later on. But this is the end result of your thinking. Okay, so it's not just about memorizing the muscles, that this muscle does this, this muscle does that. That's good, but it, you know, especially with the exam questions, they're going to ask you which muscle has an attachment to the humerus. Like that's too basic for them to ask. A lot of their questions will be clinically based. So, for example, if the axillary nerve, if somebody was in a car accident and their axillary nerve was cut, which of the following symptoms would they show? You could memorize it, or you could logically deduce, okay, based on my knowledge of the innervation of the muscles, based on my knowledge of the functions of the muscles, what symptoms is this person going to show? And you can start to think like that. So that, in my opinion, is the end result of all of this learning. So if you can start thinking like that as you learn, you might see the purpose in understanding the nerves, understanding the blood supply, understanding the different, you know, functions of the muscles and stuff. So hopefully that can give you a little bit of perspective on what you're actually learning, and it's not just learning a bunch of stuff for the sake of stuff. Now, there is stuff for the sake of stuff, like ligaments and you know, random muscles that you've never heard of. But you know, you just got to do those as well, just in case. So yeah, all right. So we won't go through all different muscles here. Pecs, obviously, again, you can see where it attaches and infer what's going to happen next. So yeah, so we want to do all this. And so yeah, all right, blah, blah, blah. Which you get to your upper arm muscles, a little bit less. All right, so you got your anterior and posterior compartments. The reason, again, that I've categorized, it's good to just understand these categories is, as you see when it comes to nerves, if I say the muscular cutaneous nerve innervates the anterior compartment of the upper arm, you should know, okay, well, what muscles is involved in that, rather than me say the muscular cutaneous nerve innervates the coracobrachialis, the brachialis, and the biceps bronchi. I can just say it innervates the anterior compartment of the upper arm, and you should know which muscles are involved. So it's good to know the categorization of the muscles as well. So yeah, again, you can sort of figure out what the functions of each muscle are. We won't go through those. Yeah. Blah, 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 blah. Yeah. All right, so again, forearm muscles, this is a hefty list, I'll be honest. I still don't know. I mean, it's, you know, I don't know the forearm muscles. There's just too many to remember. But you will probably have to do that. So again, different compartments: superficial, intermediate, deep, superficial, deep. Again, some of these relate to innervation, but you should categorize the muscles that way, rather than listing, you know, all 7 of these. You can say this nerve innervates the superficial posterior compartment of the nerves. Okay. Now, just again, I won't go through all the muscles, but just a little bit of a helpful tip. You'll see a lot of these names give you clues as to what the function of the muscle is. For example, and I don't know if I think I go through the Latin terms either on the next slide or later on. But anyway, flexor, obviously, you should be thinking, okay, well, that muscle is going to be involved in flexion. Okay. Carpi is the Latin word for wrist. Ulnar Radialis. I'm sure you can put 2 and 2 together there. digitorum is your digits, your fingers. Superficialis is superficial. Okay, so the digitorum superficialis is not going to be in the deep compartment. It's in the intermediate here, but it's kind of iffy. All right. Profundus is deep. So it's going to be in the deep one. All right. Now, pollicis, I will go to the Latin names in a second, but basically my point is, if I asked you, okay, well, what does the flexor digitorum, actually, what does the flexor carpi ulnaris do? Where is it? Okay, obviously, you know what it does. It flexes the wrist, okay? But where it is, you could think, okay, well, it's a flexor muscle. So on my arm, so you can see my arm, on my arm, okay, if I'm going to flex my muscle, where is it going to be? It's going to be on the front, right? Because if it contracts, it's going to flex. There's no point in being on the back. All the muscles on my back are going to be for extension, all right? So my muscle is going to go on the top here. Wrist is going to have to kind of connect, it's going to have to attach onto the wrist and probably attach on my elbow somewhere. And it's ulnar side, so it's probably on the ulnar side of my arm, okay, where the ulnar bone is. So, you know, if I look at a diagram about, okay, well, that looks like that muscle looks like it will be flexing the wrist based on its attachments and its location. For example, the extensor digitorum, okay, that's going to be extending my fingers, which means it's going to come along the back, because that's, if it contracts, that's what you're extending on your fingers. And it'll probably attach along my finger, the phalanges somewhere here, again, attach somewhere along my forearm there. Supinator will supinate my arm. If you want to supinate my arm, you're going to have to come across, I guess, this part here. So if it contracts, you can turn it. So that kind of thinking is, again, what I use to just save myself having to do a lot of memorization, and it's more sort of logical thinking. Another way to just think, I guess, is especially with the hand muscles as well. Again, a lot of these are hand muscles, like extensor pollicis brevis, extending the thumb, and it's a short muscle. Okay, so a lot of the hand muscles are actually in the forearm. So that's a bit deceptive. But yeah, a lot of the hand muscles as well will have a short and a long arm. So if there is a extensor pollicis brevis, there's probably going to be an extensor pollicis longus. Okay, if they've gone to the effort of saying flexor digitorum superficialis, there is going to be a flexor digitorum profundus. Otherwise, they'll just say flexor digitorum. There's no reason to add that extra part. So that could be another clue to help you remember the different muscles there as well. Okay, actually, here are the Latin. Again, just, you know, you don't have to know this, but it just helps with, if someone says flexor carpi radialis, I can go, okay, it flexes the wrist and it's on the radial side of the muscle, radial side of the arm. Okay. So indicis is the index finger. So the separate, some muscles only flex certain fingers. So pollicis is the thumb, digitum minimis, the little finger, and yeah, we cover the rest. Carpi, like carpal, right? That's like your wrist, carpal bones. We're gonna move that. Okay. Oh yeah, so again, you know, logically you can determine what do you think the function of these are going to be, right? Yes, we won't go through a lot of these. Yeah. You can see a lot of the extensor muscles, again, logically, they're going to be on the back of the arm. They are extending all the fingers. So yeah. I'll go through all of these. And your hand and wrist muscles, again, there's a fair few of them, all right? A little bit easier to remember, I think. But yeah, that's just my personal opinion. So your thenar eminence, so we'll just cover it here. Your thenar eminence is basically your thumb muscles. Your hypothenar eminence will be your pinky muscle, and then there's a bunch of other stuff that kind of comes in between. Fun fact that I was taught, if you look at your hands like this, all right, for those of you, you'll see, I think for most of you, you'll see your dominant hand, your hypothenar eminence on your dominant hand will be a lot bigger than so for me, it's my right hand. So if I look like this, you'll see that there's a bigger lump around my hypothenar eminence on my right hand than there is on my left, which I just thought was interesting. Obviously, because you're using it a lot more, it gets bigger. So yeah. And similarly, I don't know, this is particularly interesting to you, actually. It might be a bit hard to demonstrate, but there's another way you can sort of see the hypothenar eminence at the back as well. You kind of squish your thumb and index finger together, but a bit harder to demonstrate. But anyway, just a little cool thing to have a look at. So yeah, opponent's pollicis, easy. Opponent's opposite, thumb, opposition of the thumb. Okay. You know, it isn't as hard as you think it is. It's just about remembering all the different stuff. So yeah, and obviously you can see, you know, as I draw these diagrams, I'm labeling the orientation so that someone who reads this can see, okay, what am I looking at? So if you're not familiar with those terms, it can be a little bit hard to very quickly orientate yourself around an image, which, you know, you should be able to do. Okay. Yeah, I won't cover all this. All right. Okay, so those are the muscles, and hopefully that was helpful. So now on to the nerves. So the big, I guess, hurdle with, well, not hurdle, but the big thing you need to know here, the biggest thing about upper limb is this thing called the brachial plexus. Plexus just means a bunch of nerves like kind of just coming together. And so there's a bunch of plexuses around the body. The big plexus for your leg will be the lumbar plexus. And this is something you've got to be around this. And it basically looks like this, right? Or like this, okay? Which might look a little bit intimidating, all right, to memorize and understand. So just for your benefit, I'll break it down a little bit step by step here. Again, not that you have to memorize it right now, but so that when you see it in your lecture or your tutorial, you kind of have a basic understanding of what's going on. So if you have a look at our little friend here. Okay, now I'm going to remove the clavicle just so it's a little bit easier to see, but just be aware that your brachial plexus will come down and underneath the clavicle. Okay, so for example, if somebody has a clavicular fracture or a clavicular injury, but let's say a clavicle fracture, what's a big danger? Damage to the brachial plexus, because the plexus runs underneath the clavicle. So if you fracture it, you might have a risk of some damage. Okay, so all of this stuff should be, you know, piecing together as you learn. I think keeping that in mind is going to be particularly helpful to give you some purpose with what you're learning. But okay, so I've removed the clavicle, so it's a bit easier to see in my diagram fits. But that is your brachial plexus and around about where it's going to be. Okay, and all of these nerves will then come down the arm. All right, so if you kill the brachial plexus, you will have no movement in your arm. So all the movement from the arm comes from these 5 nerve roots here. So if someone cuts those off, you can't move your arm. Right, so if you have a clavicle fracture and all the brachial plexus is damaged, then the guy shouldn't be able to move their arm. All right, well, let's break it down a little bit step by step. So first off, we've got, so there are 5 sections, okay, but the first one is called the roots. So the nerve roots. Again, you should have learned some of this in your year 1 neurophys or neurology, or whatever you call that. But basically, nerve roots will come up directly off the spinal cord. Okay, so these are sort of the closest you'll get to the brain, I suppose. So you've got C5, C6, C7, C8, and T1 nerve roots. They make up the brachial plexus. Sorry, and just as a bit of revision, these are your, sorry, C7, C7, C6. These are your vertebrae, okay? Again, which will be, when you learn about again when you do back and spine. But you'll notice that there's no C8 vertebrae. Okay, and so that's the anomaly. So there is a C8 nerve root, but there is no C8 vertebrae. So just keep that in mind. So yeah, okay. And so these roots then converge or don't converge into trunks. So the C5 and C6 nerve roots come together to make the superior trunk. C7 continues along the middle trunk, and the T1 and C8 nerve roots make the inferior trunk. Then these split off and converge and diverge into posterior and anterior divisions. So you'll see that nerves from all 3 trunks, and therefore all 5 nerve roots, come to make the posterior division. Again, this will be important in a second. So when you see what nerve roots make up which nerve, and then they will then again become some cords. And you'll notice all these little nerves coming off the main trunks, divisions, and cords and branches. And these are nerves by themselves. And if you remember from the other diagram, there are little things coming up, little diagonal lines, smaller nerves, okay? Not one of the big 5 that we'll touch on right now. So these are the big 5 here. But these other ones are smaller ones that you should know, but they're not as important. Okay, these big 5 nerves here, these nerve branches, so muscular cutaneous nerve, axillary nerve, radial nerve, median nerve, ulnar nerve, they will operate the majority of all the muscles in the upper limb. The smaller ones will play, a small part here and there, but for the most part, the majority of the muscles will be operated by these 5 nerves. All right, and so you'll notice if you track the C5 root, that makes up the muscular cutaneous, the median, and the radial and the axillary nerve. Okay. Actually, I'm not sure if it does all of them, but we can see in a second. But that's the kind of logic that you might think. So instead of memorizing which nerve roots make up the musculocutaneous, if you're familiar with the diagram, you could sort of piece together, all right, which nerve roots are going to, you can track it and say, okay, which nerve roots are going to correlate to which nerves. Again, if somebody has C5 damage, which nerves are going to be affected, et cetera, et cetera. All right, so that's why it's important to understand the brachial plexus. And I think the lecture will actually go through this. But when you first see it, it might be a little bit confronting. So watch a video on it. Just find some way to understand it, because this is very, very important. So yeah. But if we return to, okay, so if you return to this is the same thing, but it's just converted into like a, I guess, a less drawing diagram, more straightforward, but it's the same thing. Okay, you'll see all these little nerves here that come off the main ones. Still important, but not as important as these 5 here. Now you'll see the musculocutaneous is made up of C5, C6, and C7, right? Auxiliary C5 and C6. Now you'll notice that there's a bit of C7 coming down to the auxiliary, but I guess that I don't have an explanation for that. I think it just means that the branches that come down here just go straight to the radial, and not really the auxiliary. So it's a bit iffy. So it's not 100% sure. You're not 100% guaranteed to get it right, but you can mostly get it correct. For the purposes of clinical examination, that's what you may need to know. Or you can just memorize. Actually, to be honest, it might just be easy to memorize these because it's not too difficult. So you can see radial and median have all the nerves. Ulnar and axillary only have 2, and musculocutaneous has 3. But yeah, I'll leave you to memorize that in your own time. All right, now for each of the 5 big nerves, these are going to be important, again, clinically. So when you do your clinical skills, right, this is where everything connects. Okay, your rotator cuff injuries, your nerves. If somebody has particular nerve issues, what are their symptoms? Because in your clinical skills workshops and your examination of the musculoskeletal system, you'll be doing various tests to see if they have function of, if they can abduct their arm, or they can, flex their fingers, and that can give you indications of what damage they may or may not have. So yeah, so we'll start off with the musculocutaneous nerve involving the C5, C6, and C7 nerve roots. And well, actually I've shown you on the right here, those are all the muscles that the musculocutaneous nerve innervates, and we can see a relative pathway of the muscle itself. But if you have a look closer, okay, you see that obviously this is part of the brachial plexus. It goes underneath, and out of the brachial plexus comes the musculocutaneous nerve. It comes through the coracobrachialis. Okay, so let's say someone tears the coracobrachialis. What's the first thing that should come to your mind? Oh, musculocutaneous damage, because the nerve goes through the muscle, and then it comes through here. So if the muscle is coming through here, through the upper arm, okay, obviously I've shown you on the left what it innervates, but it's cutting through the anterior compartment of the arm. What muscles is it going to innervate, right? It's going to innervate the anterior compartment of the arm. So the brachialis, the coracobrachialis, and the biceps brachii. Okay, it's not going to innervate the triceps because that's behind. So how could it innervate, right? So logically, if you understand, or well, personally for me, I try to understand the pathway of the nerve through the arm, and then I could logically determine most of the muscles that it innervates. And therefore, if the nerve is not working, I could infer what functions are not going to be working, and therefore what symptoms the person will be displaying. So actually, we'll touch on that in a second. But as well as motor innervation, you need to be familiar with the sensory innervation of the nerve. Again, if they have no damage, they might lose sensation in their feeling, in their arm. Now, there is something called dermatomes and myotones. You'll cover that in clinical skills. That just tells you the muscle areas and also the movements and the skin areas that are covered by each nerve root. Won't go through that now. It's not terribly important at this stage, but you should familiarize yourself with that because it's important clinically. But just a heads up. So sensory innervation of the musculocutaneous nerve. Now you'll notice, hang on, there's no muscles here. So what is it doing? All right, so it only innervates the anterior compartment of the arm, your biceps and stuff. Right, so this part here is actually called the lateral cutaneous nerve, but it's just an extension of the musculocutaneous. And that all it does is sensory innervation. So it'll innervate this kind of lateral anterior portion of your arm. Okay, lateral anterior, but it's a bit lateral. Right? So again, using those descriptive medical words to describe where it is. So again, if somebody loses sensation there, you can be like, okay, well, since I know where the musculocutaneous has sensory innervation, I can deduce blah, 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 blah. Okay. So clinical relevance here, what symptoms would the person display if the nerve roots C5, C6, and C7 were damaged? This is a type of kind of a more mundane version of the question you could get on your exam. So, we know that from our revision and our learning that the musculocutaneous nerve is the nerve that comes off the C5, C6, and C7 nerve root. So if they're damaged, anything that is touched by the musculocutaneous nerve will be either damaged or gone. Oh, sorry, have loss of function or complete loss of function. Okay, so if, so for example, you might not be able to, well, actually, if the musculocutaneous nerve is damaged, you won't be able to, what? Flex your elbow, because that's what the biceps do. That's what the brachialis does, right? If somebody can't flex that, you'll be like, okay, well, it could be a musculocutaneous issue. So one of the symptoms might be inability to flex forearm. What else might they have? They might have loss of feeling in the lateral anterior portion of their forearm. Okay, so those are the symptoms that they'll elicit because, and you're able to tell that because you know what the function, the sensory and the motor function of this nerve is. And so that's why I'd encourage you to sort of think in that way as you learn this kind of stuff, because it gives a bit of perspective to what you're learning, and you're not just mindlessly memorizing stuff like for VC. Okay. Axillary nerve, this one's a little bit easier actually. It's just C5 and C6, and it just touches on the shoulder. Okay. So all it innervates is the deltoid and the teres minor. As we did touch on this a little bit before, what would happen if the axillary nerve was damaged, blah, blah, blah. Okay. So as you can see, it comes off the brachial plexus here and then just wraps around the shoulder. All right. So for example, if you were to have a humeral fracture, so this part, or a shoulder dislocation, what might happen? You might have some axillary nerve damage. Okay. So yeah, but pretty straightforward on that account. Sensory innervation, just innervates that part of the arm, pretty logical, right? Just for your information, this is actually called the regimental badge area, because that's kind of, you think about like army folks, they have their little arrows and whatnot on this side of their thing. That's called a regimental badge. So if you hear the regimental badge, that's what it refers to, just the area of axillary sensory innervation. Okay. Radial nerves, that encompasses all 5 of the brachial plexus. So for example, if the C5, C6, and C7 nerve roots were killed or cut, you won't lose radial nerve function, but you'll have a significantly decreased radial nerve function. Okay. So you could still have weakness. You might have muscle weakness, but it won't be completely gone. As you can see from the diagram here, again, brachial plexus comes off the brachial plexus, goes behind the humerus, which means what muscles is going to innervate? The posterior compartment of the arm, and the only thing in the posterior compartment of the upper arm is the triceps. All right, then it comes down into the front, again, the radial side. It's called radial nerve, so it'll be on the radial side next to the radius. All right, and so again, what muscles are on the radial side of the forearm? Well, those will be your extensor muscles, right? So again, in my just based off this, if I had to guess what the main function of the radial nerve is, extension of the elbow for the triceps and extension of the forearm for all those extensor muscles. So yeah, posterior compartment. Oh, yeah, you go. Posterior compartment of the forearms. All those muscles there. So I don't need to bother. I mean, you should remember all of them, but it's not necessary for you to memorize all of them for like clinical purposes. For example, if you're thinking about function, as long as you know the broad function, for example, the supinator, they can't supinate their forearm, for example, or I forgot the function of this. I don't know where that is, but whatever that function is, it'll be it. Extensors, abductors. All right. So if you think about it like that, they're a bit easier to understand what's going on and what consequences are going to be the case if it's damaged. Okay, a little bit more clunky sensory innervation, but that's the general gist. Is most of the dorsal, sorry, not dorsal, well, actually yes, dorsal, but a lot of the posterior forearm. And you'll notice again, if you were to like superimpose all of those sensory innervation pictures, you'll see that the arm will be covered. So I think this was muscular cutaneous, and I think this was muscular cutaneous as well. All right, so just a little fun fact for there. So again, if you had a humeral shaft fracture, again, I'm using those descriptive words, so you need to be familiar with the location of the bones. Whereas a humeral shaft, that's this part, so therefore a humeral shaft fracture will be along the shaft. Okay, what can happen? Well, actually, there's a thing on the humerus called the radial groove, which is where the radial nerve sits. All right, so if you have a fracture there along the back of the humerus, what can happen? Right, you will lose function down here. Okay, you might not lose. I mean, depending on where it cuts. Right, if you cut the radial nerve like here, you won't lose function here, obviously. But yeah, if someone has a humeral shaft fracture, you should be thinking, okay, do they have any symptoms of forearm muscle weakness or inability to extend their elbow? Right, then you can think, okay, it must be some radial nerve damage. Right? So there's another example of how you might be thinking, or how you should be thinking, in my opinion, when it comes to nerves, muscles, functions, and all that stuff, and blood supplies we'll talk about in a few slides. Median nerve, same as the radial nerve, okay, in terms of the nerve roots. They're slightly different location, though. It comes down in front of the forearm. So remember what muscles are in the front of the forearm? We've got the flexor muscle. So the big thing will be flexion of the wrist. Okay, it has no forearm stuff though, so no issues there. All right, so again, just for me, a way for me to remember is just categorizing the muscles by compartment. I know the median nerve innervates the anterior compartment of the forearm, the thenar eminence of the hand, and some lumbricals. Okay, obviously all the anterior except for this particular muscle, okay, which is innervated by the ulnaris or the ulnar nerve, and this is just an acronym that you can use. Okay, but I won't go through that too much. All right, and then your sensory innervation of the hand, blah, blah, blah. You can, again, logically determine that since the median nerve runs in the front of the hand, your sensory innervation of the hand is going to be in front. It's the C8, oh, sorry, the ulnar nerve, C8T1. Okay, again, kind of running a little bit more posterior, and you'll see it runs behind what is called the medial epicondyle. So these are epicondyles. That's lateral, it's medial. Okay, you'll learn about them later. But you'll see the nerve runs behind the medial epicondyle. So if you, obviously I can't do it because I have a jacket on, but if you kind of feel like you have your two epicondyles here, right, you have to take your jackets off, whatever, to feel it. But if you feel behind your medial epicondyle, you might be able to feel the ulnar nerve. You'll see this little like, sort of ropey thing that's moving back and forth as you press it. Okay, that is your ulnar nerve. And so what happens is, you know, when you have like a funny bone, when you hit your funny bone, you have this weird feeling. That's your ulnar nerve being hit. And so it gives you this tingly kind of feeling. So the damage to the not damage, but like sort of the ulnar nerve being affected a little bit is what gives you that funny bone feeling of tingling. So just another little fun fact for you there. But yeah, as you can see, it comes behind and it kind of stays a little bit posterior and it comes to the hand. So again, what muscles is going to innervate? Well, it's going to be the ones that are in that posterior area, posterior medial area-ish. But it does a lot of the hand stuff as well. So again, there you go. Let's go to that. Okay. And again, sensory innervation basically innervates the majority of what the median nerve doesn't. Right? The radial does a little bit of the hand, but the majority is ulnar and medial. So if somebody presents with tingling in their pinky finger and their ring finger, right, you'll be thinking, okay, it could be ulnar nerve issues, all right? And you'll do your neurology examination later on as well, where you talk about this stuff later. But okay, vasculature. So this, when I say vasculature, we mean veins and arteries. So both of them together. And so neurovascular will be nerves, veins, and arteries. There's also lymph stuff, but it's very minimal. So I didn't bring it up here. But Don't worry about that. All right, so these are the arteries of the forearm, the major arteries. Obviously, there's all these little ones, but these are the major ones that you should know. Okay. Again, I'll just go through them visually. So hopefully you have a general, so when you see a specimen, you kind of have a general idea of the location of every artery. So we'll start off with the first one, the subclavian artery. Again, think about the name, subclavian, subclavicle, under the clavicle. Okay, so the subclavian will come off your aorta, I think some part of the aorta, and then it comes underneath the clavicle, subclavian artery. Okay. And then all right. But then we have your axillary artery. It's all the same. They just change names. Okay. So axillary artery comes through your axilla area. All right. And then you have your brachial artery, which is down your brachia. Okay, bronchus, you know, your biceps brachii, your brachialis, brachii is like your upper arm area. Yes, again, you can use these clues to understand where everything is. And you'll see these two little circumflex arteries that will come off here. They're small ones, but the reason I mention them is because if you have a humeral fracture, you know, what do you think is going to happen? Right? These arteries are going to be damaged, or they can be damaged. So again, bringing you back clinically to see, you know, what, I guess what's important and what, maybe, yeah, if you're a doctor, you'll be thinking, okay, well, maybe we need to repair those arteries or blah, 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 blah. I'll just double check something actually. Yeah, okay, so just in case you are wondering, how do I know where the artery changes from subclavian to axillary, blah, blah, blah. Actually, under the clavicle is where the subclavian changes into the axilla. And here, well, this is a terrible drawing, but let's pretend this is your teres minor. As the artery crosses the teres minor, it goes from axillary to brachial artery. Okay, so just useful things to be aware of. Okay, moving down the arm. All right, we now enter into the radial and the ulnar arteries. The brachial artery is coming down, 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 down. Then we split off into the radial, and obviously it's not super accurate, but radial and ulnar arteries. Okay, and they'll travel down, 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 down. Okay, let me just get rid of that. Oh, actually, before we continue, fun little thing you learn about some clinical skills, but I found it very interesting when I first learned it, is feeling your pulse. So I'm sure most of you know how to feel your radial pulse, which is basically just, I guess, with your arm, radius, ulnar, feel your radial pulse. That's the common one that people feel for. All right, put your two fingers there and you'll be able to feel it. Your brachial artery, which basically, I guess it's a bit hard to show my jumper here, but if you kind of half flex your elbow and you kind of press in the middle, you'll feel this ropey thing. So that's the biceps tendon. Okay, and if you go a little bit lateral to it and press, so you have the biceps tendon, move laterally and you press, and then you extend your elbow, you should be able, you don't have to extend it, but you should be able to feel the brachial pulse. Obviously, I can't feel it through my jacket, but that's kind of where you should be hitting for the brachial pulse. So I found that very interesting when I first learned it. But yeah, anyway, so you'll cover all of these when you do your clinical skills examinations anyway. And then your arteries come into the hand. So your radial artery, remember, where is it? It's coming around here. Ulnar artery is coming around here. And what happens is they basically like just join, or what this is called is they anastomose. The two arteries kind of connect. And that basically gives you your superficial and your deep palmar arches. And then these just extend out into your fingers to become the digital branches. So yes, so that is basically all the arteries or the main arteries in the arms. Okay, so again, if somebody, so clinically you should be thinking, okay, what happens if this happens? What happens if this happens? Right, what nerves are going to be affected? What artery is going to be affected? That can be a good way to contextualize all the information you're learning, easier to remember rather than just memorizing them off Anki flashcards. But anyway, that's just my opinion. As for the veins, now you'll notice it's very similar to the arteries. Okay, what happens, well, basically, if you're not familiar already, is the veins drain your blood away from your distal areas of the body to the more proximal, right? Because obviously it's going back into the heart. Okay, so most of the veins, not all, most of the veins will follow the arteries. Okay, so you'll see it's basically the same way, but it's just going backwards from the hand backwards into the subclavian vein, back into the heart. Now, often though, you will have extra veins. So these are your superficial veins, and they follow the arteries, but you will also have deep veins, which will not follow the arteries. So often you often have a little bit extra. And just a little bit of it, just, I guess, a factoid, I guess. If you're wondering how the blood gets from the veins into, how does the blood move upwards, right? Because arteries, when you pump blood out, gravity is helping you move the blood down into your legs and your arms. Okay, so how does the blood, especially from the superficial venous arch, how does that get from your hand up into your arm and into your heart? You learn about it a little bit more later on, but in your neurophys stuff later in Sem 2. But basically, just so you understand, for these particular veins, they move along the arteries. So as the arteries pulse, the pulses will also help the veins, which are next to the arteries, to push blood. So that's one mechanism. Another mechanism is when you move a muscle, it contracts, and that squishes the blood. It basically helps, especially in your legs, helps push the blood back up. But anyway, so I'm kind of getting off track here. But that, if you learned about envenoming in semester 1, what you should do in first aid if someone gets bitten by a snake, that's why they say don't move. Because if you move your muscles, if you move your leg, you're gonna be pushing the blood back up, right, through the veins. So then then the venom is gonna be coming back into your heart and then back into the circulation. So that's why they say pressure immobilization. So you just gotta immobilize, don't move it, otherwise you'll be moving the blood back to your heart, which obviously you don't want to do. So yeah, fun factoids. But yeah, so the deep veins, so these are the new ones. These are the cephalic, basilic, and medial cubital veins. They're pretty easy to remember. Can't remember if I drew anything of it, but just in case I didn't. All right, so basically, in a nutshell, your cephalic vein is here, your basilic vein is here, all right? And your medial cubital vein, which is the important one, is there. It connects the two in your elbow area. So that's why when people give you IV drips or they're taking blood, or if you go for a blood donation, they often put it there. That's often where they put your needles, is in this medial cubital vein, which is just in your elbow area. So another fun factoid for you. So yeah, it's commonly used for IV drips and stuff. So again, I personally like to kind of relate all this stuff to something, so it's a little easy to remember. So it's not just some arbitrary thing that I have to remember has some sort of relevance, but that's just me, again, personally. But another tip for you if you want to sort of help yourself remember all this stuff, because there's a lot, let's be honest. All right, and finally, got a couple of anatomical spaces. All right, very few, but the axilla is an important one. So you'll notice axillary nerve, axillary artery, that all comes from the axilla, which is this basically your armpit area in a very layman's term. Okay, but it's this weird, not a pyramid, but it's like some sort of prism shape. It's not an actual thing, they're all spaces. Okay, but you will need to remember the different, the base. What's the base? What forms the base? What forms the lateral border? What forms the medial border? What forms the posterior border? What forms the top? Okay, I haven't put it here. But again, it's in my notes, but obviously, when you learn it, you should remember all this stuff, because that can be common questions they ask. But yeah, knowing what goes through as well is important. If somebody gets stabbed in their armpit, which I highly doubt they will, but they could give you a question like that. What is going to be damaged? Your brachial plexus, your axillary arteries, veins. There are some lymph nodes that you will need to know in the axilla. I won't go through them now, but that is also important to know. Okay. You've got the cubital fossa. This is the next space. So this is in your elbow, forearm. So once all the muscles are sort of there, you sort of see this little, I don't know why they call it cubital, but it's like a little triangular prism shape. I don't know if you can make that out, but it's like a little triangular prism that kind of goes inwards into your arm, just by all the muscle formation. Okay, and that's where your medial cubital vein is. So that's where you put your IV stuff in. But again, where all your other nerves and arteries and stuff are. It's good to just know what's in each one, just in case they ask, and what the borders are. So for example, the lateral border, I'm not going to say left border, lateral border is going to be the brachial radialis. The medial border of the cubital fossa will be the pronator teres, and the superior border will be biceps brachii, I think, but also there might be more deeper in. But yeah, I don't know if this is the last one, but carpal tunnel. So I'm sure most of you have heard of carpal tunnel syndrome. Okay, that relates to carpal tunnel, and that's basically nerves and tendons running through your wrist, covered by this ligament, which I think is called the flexor retinaculum or something. But basically, again, clinically irrelevant, because if you have carpal tunnel syndrome, what nerve is going to be affected? It's going to be the one that goes through the carpal tunnel, which is the median nerve, which means what are you not going to be able to do, right? And again, how can you get it? Well, if you continue to sort of, I guess, I don't know if you're working on a computer or you're having some sort of stress here where the flexor retinaculum is continually pressing against the nerves and the tendons, you might get some neuropathy in your hands where you get tingling and some nerve issues there. So again, always making these connections just so it's a little bit easier to remember and everything stays contextualized, I guess. Okay, so last one. The anatomical snuff box, which basically is if you, I don't know if you can do it, I might not be able to see on my hand, but if you kind of put your thumb backwards like that, you might be able to see some tendons that join up to make the thumb, like that's depicted in the image, and you see this little depression. And I'm kind of skinny, so it's a little bit easier to see. But that little depression is the anatomical snuff box, and included in there is a radial artery, and you might actually, depends, but you might be able to feel your radial pulse if you press into that snuff box. Might not, but again, just clinically, just so you know, so you're familiar with it. Basically, what might happen is if you have a scaphoid injury, remember scaphoid is one of the carpal bones in your wrist. So if you have a fracture, if you land on your hand, for example, you fracture that, you know, again, you'll learn this, but clinically, the radial artery runs through the scaphoid. So if you know, there might be some damage there, and that, or again, it's in the anatomical snuff box area. But yeah, anyway, those are just important spaces to know. But there are some more. Those are just the main ones, just to familiarize yourself. If they ever bring it up, you can remember those. But yeah, that's basically an overview on the stuff that you need to know. Obviously, you know, there are ligaments, deeper nerves, deeper veins and arteries, and a lot more sort of intricate stuff, but that should cover you for a lot of the stuff they'll bring up in the imaging, the specimens. And so hopefully you're not sitting there like me last year going, you know, what the hell is going on, and getting completely demotivated and not turning up to tutes. Please turn up to your tutes. But yeah, hopefully this will stop you from being demotivated and feeling like it's just getting too much. So yeah.
Okay. A huge thanks to Raman. That was amazing. So yeah, a lot of effort there, and I think everyone can really appreciate going through that. Would have loved to have Raman explain me all the anatomy last year. But all right, so we got a lot of chat questions. So I thought we'll do a quick Q&A, and Raman, you can also help. We had a lot of questions about the 3D models. So what 3D models were you using, by the way?
Oh, me. Oh yeah. So there is, you know, you might have heard of this app called Essential Anatomy. There's a new app, and it's also on the computer, I think, Essential Anatomy 6 or something like that. That one is quite good, but it's expensive. It's like a subscription. So you might, I know people who like joined up together, like a couple of mates just shared the cost. I just bought the previous version, so Essential Anatomy 5 for $20, but that's not a subscription, so I just have it now. But because we did not have any live specimen classes, I'm a visual person, so that helped me just, because you can like put like muscles and I'll actually show you. But it just helped me visualize the nerves and the muscles, because I'm a visual learner. And so we didn't have we were looking at images, right, for our specimens. And so it was pretty, not very suited for my particular learning. But hopefully you can see. So this is the app. And basically you can like, I guess, also because my notes were I didn't want to draw all the bones and stuff, so I thought I'd just take pictures of this instead. But like you can like add muscles and sort of just, I don't know, look at where the nerves go and stuff like that. So you can play around with it, and it just helps visually with the learning, I suppose. For me personally, especially, I know maybe you guys might find it worth it because half your specimens might be online. I'm not sure what the gig is there.
So this was Essential Anatomy?
Yeah, so this is Essential Anatomy 5. This is the previous version. There's a new one, but that's subscription based, whereas this one's just $20, one-time purchase. So, but there is a newer version.
There are free ones. Like, I know a lot of people started using like BioDigital. I'll put that in the chat. I use that for a bit, and like it was like it's fine. Like it's nice for visualization, but obviously I don't think it'll be as complete as like those other anatomy ones that are paid.
Yeah.
The fact that the start of this year, like they introduced like this online 3D software, but I forgot what it's called. I'll have a look and I'll put that up on like a post. But the fact that I forgot, it wasn't the best software, if I remember correctly. Rama, do you remember?
I don't remember. I was just using this. I didn't really pay attention to what they were talking about.
Yeah, it's not as good as like these other apps. But yeah, like it depends on you essentially, and how you study as well. Raman, there's a question about if you can get essentially more than one.
With this particular app, I'm sure if you signed in with like the same Apple ID, like you know how people like share apps if they pay for something, I'm sure you could do that. I think it should be fine. Like I know a friend who him and some other guy got the newer version of this app, which is like $80 a year or something. I don't know, something like that. And they, as long as you sign in with the same Apple ID, I'm sure you'll be able to download it and it's fine. Or the same account. I think you can download the newer app. You can download the app, but you have to sign in with a paid account. And if you have the same account, I'm sure it'll be fine because they do it. So it should be okay.
Robert, do you have does this have like a movement in it? Like for the muscles and stuff?
No, not this one. The newer one, maybe. They have a free trial. You can get the free trial for like 2 weeks and you can see. But I can't remember if the new one is movements. I don't think so.
I would definitely try before you buy.
There's 2 weeks free trial of the newer version of the app. So you can just use that.
Okay. So we have some more questions as well to go through. All right. So someone asked about the difference between intrinsic and extrinsic muscles. So in their purest form, extrinsic is when the muscle originates somewhere but acts somewhere else, right? So for example, if we think about the muscles in our forearm, the superficial ones, the ones at the top, they start in our forearm, right? But they actually work on our hands. So that's an extrinsic muscle. Now, intrinsic would be perhaps the muscles inside our hands, right? Like that big thumb part, that's one of the muscles. I forgot what it's called, but it's a muscle. And that starts in your hand and it acts in your hand. So that's an intrinsic muscle. Now, you'll see there's you'll see in parts of the body, there might be some other additional rules. There might be some specific purposes, but that's the most basic difference between them. That is the difference.
Yeah, no, that makes sense. Because if you think about the extrinsic shoulder muscles, like your trapezius, which is all the way down your back, and your pectoral muscles, they're not in your shoulder. But the deltoid and the rotator cuff, they're all intrinsic because they're in your shoulder. So that makes sense.
Yeah. Some questions on is there a systematic way, to learn everything? Ryan, what do you reckon? Is there a systematic way to learn everything?
I'm sure there is a systematic way. The way that I did, it's not the only way, but it's the way that I organized my notes and my learning was basically 2. So I did so I grouped the muscles, the ligaments, the bones, and the anatomical spaces, all based on location. So first I did the shoulder joint, then the upper arm, then the elbow, then the forearm, then the wrist. I actually spent a lot of time thinking about how I could organize it, and that's what I ended up with, was just treating it like separate joints, because the muscles and stuff work together with the ligaments, and I just thought it'd be better that way. But you could also do it as all muscles, all bones, all sort of spaces and stuff. Up to you. I mean, there's no huge benefit. The main benefit for me was just notes wise, it was nicer, but learning wise, I don't really think it's a big difference.
I agree with Raman. I did it similarly, by location, so shoulder joint going down the arm. But yeah, he's right. Again, there's many different ways you can do it. I think looking at the PSBs as well, seeing the way that they structure their content, that's often like faculty is amazing, anatomy faculty is amazing, and they've made amazing changes as well for online learning over this past year and a bit. But still, the way that the PSB structure all the content feels a bit more complete and a bit more logical as well. So it's nice to look at how they go through the content to get an idea for how you might want to run through the content.
Yeah, especially because anatomy, when they teach it to you, is broken up. You don't. The main issue that I had was you couldn't see far ahead. You didn't know what was coming up. So that's why with the PSBs it was nice. They had like the whole thing completed, so you could see what you're going to learn and you could sort of categorize and break up your learning accordingly. But for the nerves and the arteries and the veins and stuff, I would recommend doing that as a whole. Like I said, it's good to see the whole pathway of the nerve and the artery, so you can sort of see very clearly what's going on, as opposed to sort of segmenting it and then losing track of its like location in the larger scheme of things. That's just my
So we had a question about the like logical deduction of what nerves do or innervation for muscles. So you can definitely like logically deduct what muscles are being innervated by what nerves, and you can do it like in multiple ways. So the way that Raman ran through the lecture, which I really like, is like the pathway or the course of the nerve, which is a great way to think about it. But also you'll realize that muscles in the same region have similar innervation. And likewise, one nerve will innervate muscles in specific regions. Like the leg is a really good example for like learning innervation by compartments, because in the leg it's basically a rule that they all follow. Like one compartment is innervated by one nerve. But in the arm it's not as like hard and fast, but still it's pretty solid.
Yeah.
Good agreement on Raman. That's good. And the question about why is the brachial plexus like named in that order in the way of trunks, cords, branches? Is there any reason behind the naming?
I could not tell you.
Yeah, I'm not too sure if there is, but we we don't really need to know either. But like I'm sure you could find out why they're named in that way. But yeah, they're not that important.
Well, the only ones, the only thing that has meaning to me is roots. The first set, which are roots, which are nerve roots, which are things that come off the spine, which I'm sure you learned in semester one anyway. But yeah, the rest, yeah.
Someone asked for the dope anatomy deck. It's on the Mumus drive under the Anki folder, like in your year level folder. So it's there, and I'll put it up as well on a post. How did you go about memorizing everything, and how often did you revise?
I didn't really do much active memorization. Again, I might be very different to how you guys can revise, but the notes for me, creating the notes was probably the biggest way that I revised, because what I had to do was I had PSP stuff, I had the lecture stuff, but when I made my notes, I had to synthesize all the information, I had to organize it in a way that I understood it. So that process of shuffling around information really, and sort of drawing all the diagrams and stuff, forced me to actually understand the content. So I can't draw a diagram if I don't understand what it looks like. I can't organize my content if I don't understand all the components. So that helped me understand. The process of creating my notes was the biggest learning, I guess, thing for me. In terms of like revision though, throughout the semester, I didn't do much because I was often behind on content. But if you do manage to stay on top of it, which I do recommend, because it can get a bit hefty. I mean, Anki, I didn't use Anki, but I know other people did. I think we did as well. And it's a good way to just keep on top of the content, because you don't want to have to sort of bulk revise. I mean, you might, that might be a thing. But you know, I would, if I had to make some suggestions, you could sort of get a couple of people and have like just, I guess, go over the content. I was going to say like a quiz, but you could sort of try, and what I did with someone this year for my exams this year, and I thought, so I'm kind of going for a tangent here, but what I thought was particularly effective for us was with like, you know, renal system and the kidneys and the lungs and whatever, because that's what we're doing. We just sat there in a Zoom and we just talked about why is this the case? Why is it that in pneumonia we can't do this? And we've tried to piece together the physiology with the symptoms, for example, and that kind of helped us understand. So if you're somebody who wants to understand rather than just memorize, it's not necessarily better or worse, but that could be helpful. You find a couple of people just every week, you know, at the end of the week, just chat about, okay, well, why is it that the why is it that when the musculocutaneous nerve is injured that this particular thing happens? And have to think about it that way. That might help you, but that's just one suggestion. But in terms of constant revision, other than Anki, I can't really, because my main thing was notes. So I don't really have another suggestion for you, but I'm sure there are stuff out there.
Yeah, I agree with Rama. Like memorizing and revising, like PSPs, they're a great tool as well. Not just for like the notes and the content, but also just for like their advice. And listen to them. I agree with Rama as well with the notes. Like I wrote notes for upper limb and lower limb, and then I trailed off to the end of the semester. And like understandably as well, I had a better understanding for the start of the semester because that's where I'd written my notes. And so for me as well, notes worked really well to like consolidate that knowledge. And it helps you, have like a place to refer back to, because anatomy is so much, you can't expect to memorize it even as you go. But yeah, I think like Anki is a really great tool for memory, but like it doesn't work for everyone. But then, like you can figure out a way eventually of memorizing it, or like familiarity even helps. We got a question about which textbooks do you recommend for anatomy? I personally didn't use like a textbook to refer back to for anatomy, but from what I've heard, Moore and Daly is a really great one for the textbooks, because it's apparently like it's very fitted towards what we learn here at Monash, in terms of like the content, and like you'll often see like the learning objectives are kind of very similar to what's in Moore and Daly. Raman, did you use a textbook?
I'm probably not the best endorser for a textbook. I didn't buy a textbook all year. I haven't bought a single textbook. I haven't touched one the entire course. I'm sure they're useful, like the clinical ones as well. And I know people who have used that Moore and Daly anatomy textbook and they like it. For me, the internet, Teach Me Anatomy internet was, and this the app, it was just enough for me to visualize it. But yeah.
And Tally and Connor for clinical skills. Like that is definitely, like, from the advice, it's really, really good. Especially when like, we're in this hybrid face-to-face online learning situation, it helps. But would you have to buy textbooks or borrow? I would hold off on buying textbooks. As Raman said, like the internet's a great resource, and so you'll find a lot of things on there, including textbooks potentially. So maybe ask around. There's a Google Drive that I know of that might have all the textbooks on there. So yeah, just wait up for that. And then also some more questions here to go through quickly. May I know what is the format of evaluating popular information assignment? Evaluating popular information assignment. I don't quite remember what assignment that is. Would you remember popular information assignment?
Popular information. Is it population health? Is that what you're talking about? Population health?
Yeah, pop health assignment. Well, there is a pop health assignment. It's a bit away though. It's not a timed quiz. It's on a quiz format in Moodle, but like it's just uploading information essentially.
Yeah, it's not too bad.
For the textbooks, I'll put it all in a post on the event page, so like we can refer back to it. What do you guys think of KenHub? Have you used KenHub before, Armin?
Yeah, when I was doing my surges, I used Teach Me Anatomy, KenHub, all that stuff. Just whoever had the information I needed. But KenHub was pretty good. KenHub and Teach Me Anatomy are both good resources. Yeah,
I agree. KenHub as well. I went on there a couple of times. Teach Me Anatomy is good. It's, in my opinion, it's like the base sort of, like it's really good on having a look at like what you need, what you should know almost, but it's not complete. And I presume it's the same with KenHub. It's not going to be complete. Amboss is another great tool, but I'm not sure how good it is for like anatomy specifically, but it's a great tool as well still.
Yeah, just be careful, because sometimes when you do look online, they can go into like, just be careful of like the depth, the scope, basically. Sometimes they don't go in detail enough. Sometimes they go into too much detail. So don't get too caught up in that and just kind of refer back. I think the PSPs are a really good, just a way to sort of check the scope of what you're actually learning. Because yeah, if you do a lot online, sometimes you can get a bit kind of lost with the scope of things. But just a word of warning.
Yeah. Okay. Any other questions from anyone, or anything we missed out on? Yeah, I'm with that pop popular information assignment. I'm not too sure exactly what assignment like we're referring to. I'm assuming it's a popular health one, the pop health one, which is like evaluating like a study. And so yes, you have a time frame where you can like prepare your answers essentially, and you can put them onto that quiz. But like it's not a time quiz. It's basically just a place for you to put up your like responses to the questions. Yeah. So you get it's a normal assignment, but like instead of putting a doc in a Google Doc, you're putting it in in the Moodle quiz. Oh yeah, I missed on this question. How do we sort through dope anatomy since all topics are mixed? Okay, so for anyone who Ankies, I'll share my screen. Just give me a second to open Anki. But yeah, there is a way of doing it. There's a way of doing it. We went through it in our Anki Zoom back in like semester 1, which was a long time ago. So I'll refresh in case anyone wants to. Any other questions in the meantime while I open that up? Sorry, it's taking a bit. I haven't used Anki in a while. Okay. Let me share the screen. Okay. So this is our Anki starting. Okay. So basically, if you want to, so you have your dope anatomy deck. If you want to like put specific cards, go into browse, and then it'll come up with this. On the left-hand side, you want to look for your dope anatomy deck, which is, give me a second, should be a somewhat dope anatomy. So if you click on this, it comes up with your deck, but they should be tagged. So they're all tagged, basically. Now, in your tags, you'll find them by dope anatomy, and then it's categorized, abdomen, back, spinal cord, whatever. So what I did, I'm not sure if this was the best way of doing it, but what I did was I would have upper limb. Whoops. They're not here because I moved them all. First of all, I'll do head and neck, for example. You just go, so you select them all. So you just select them, and then I made a deck. So basically, I would change the deck and put them into my anatomy deck. And then I'd use that anatomy deck to study. And I'd add cards as we go through the content. What I would recommend as well is, it's a bit annoying, but like I'd add like all of upper limb and all of lower limb, for example, at one time. Because looking through the content then for each week is not that useful, and plus you need that time to go through Anki anyway. So yeah, hopefully that helps. Okay, I think that's all of our questions for today. Thanks everyone for coming through. I probably should have said this at the start, but like we had random prizes, like gift cards for people who attended, so they'll go up on the event. I'll DM anyone. But yeah, so keep an eye out if you guys won those. Or let your friends know when you see their name come up, so they can get in touch for that. But otherwise, huge thank you to Raman again. Huge thanks for everyone to come. Enjoy Sem 2. Hopefully we're out of lockdown very soon.